With respect to dual antiplatelet therapy, guidelines on both sides of the Atlantic generally say 6 months of dual antiplatelet therapy for elective stenting, but for patients who have acute coronary syndromes treated with or without stenting in general, it's 12 months. That's the anchor, with a Class 2B recommendation to continue longer, meaning it can be considered, but isn't obligate. And it should be considered, I think, but in patients that are at low bleeding risk only. If patients are at high bleeding risk, I think prolonged DAPT is a bad idea beyond what the guideline recommendations that I just said were. In particular, even if a patient's at high ischemic risk and high bleeding risk, the high bleeding risk trumps. So I wouldn't recommend prolonged DAPT, but again, antiplatelet monotherapy is the way to go there. Now, in patients that are at high ischemic risk and low bleeding risk, that's a different story. That's where I think protracted DAPT can be considered or should be considered in appropriately selected patients. The primary antiplatelet agents, at least on an outpatient basis, that one would consider, of course, aspirin. That's the most commonly used, familiar, cheapest antiplatelet agent. And for chronic therapy, 81 milligrams a day is probably the way to go. My own preference is non-enteric coated, but I do know enteric coated is highly prevalent. A little bit of data suggesting that that might interfere in some patients with the absorption and appropriate antiplatelet effects. But in general, 81 milligrams a day, I think, is the way to go for chronic therapy. Of course, in an acute setting, you want to load with 162 or 325, but in general, chronic therapy, 81. As far as, and that irreversibly inhibits the platelet for its lifespan of 7 to 10 days. As far as the other broad category of oral antiplatelets, I refer to oral ADP receptor antagonists, namely clopidogrel, which is now generic and most folks are familiar with, but also prasugrel, which is going into multiple generic forms these days, so the price is dropping there. And then ticagrelor, which is also an ADP receptor antagonist. Both prasugrel and ticagrelor are more potent than clopidogrel, and clinical studies show that at least for patients with acute coronary syndromes, they appear to be better. Prasugrel specifically, that better applies to ACS treated with stents from the Triton trial, and for ticagrelor, that better applies for ACS, where in the Plato trial, ticagrelor was found to be superior to clopidogrel, including lower cardiovascular mortality. So for that reason, some have favored ticagrelor as the preferred antiplatelet on top of aspirin in patients with ACS for a year at least. And the Pegasus trial with ticagrelor, a lower dose than the ACS dose, 60 milligrams BID of ticagrelor, 90 BID being the dose for that first year after ACS. But in Pegasus, patients with prior MI, 1 to 3 years prior, there was a benefit of ticagrelor, 60 BID, when added to aspirin versus aspirin alone in reducing ischemic events. In all cases, intensifying the regimen raises major bleeding risk, but in those populations, at least it seems to be worth it, that there's a reduction in important ischemic events even beyond the year after ACS. So in general, I'd say for ticagrelor, it's got the most data, and in some respects the most robust data. And most recently, we've added to that with Themis and Themis PCI.